we will talk about syphilis. As you know, this is a big problem. I have some scary statistics. I have some pictures. You know, we are medical providers. Nobody will fall off the chair by looking at these images, but this is a big problem. Who is Anna Kortula? Is my daughter. She's a medical school applicant. She's in a gap year, and she would like to be a dermatologist. So you wait in 10 years, I will be flawless when she becomes. Okay. It's moving, hopefully. Okay. So, what is Treponema pallidum? Treponema pallidum is a spirochete. We all remember Treponema pallidum from medical school. It's kind of a spiral shaped. It's, you know, there are some other spirochetes which you remember from medical school, Borrelia, you know, leptospirosis. So there are some other spirochetes which have a similar shape. This is an electron microscopy of Treponema pallidum, which is the etiologic agent causing syphilis. There are 4 stages of syphilis. Nothing changed since we were in school. There is primary, which you remember the sore, you know, in different areas of the body. It's painless. That is very important because there are other sores which the patient can experience, which cause pain. That could be from herpes, could be from Haemophilus ducreyi. But if you see somebody with a painless sore and he meets the obvious epidemiological background, you need to think about syphilis. Secondary syphilis, patients have a rash. That's very important. We have seen a large amount of HIV positive individuals with secondary syphilis. How do I know that? Because what they tell me in their story, and you need to put gloves on because you can bring syphilis home. So when you are examining a patient with secondary syphilis, you better put the gloves on because the Treponema pallidum actively replicates in the skin. The next stage is latent. There are really no visible signs. A very common population would be a 75-year-old female who goes to the PCP for workup of dementia, and somebody checks the syphilis test and it's actually positive. So typically, or not typically, but sometimes these women have had husbands who were in the war, and you can imagine what happened there. And you know, they were infected. Nobody checked until the patient was tested for dementia, and the test for syphilis was positive. So you really see nothing in the latent stage of syphilis. And then there is tertiary. Tertiary is really neurosyphilis. You know, there could be also syphilis in the eye, syphilis of the ear, and I have seen eye about 10 years ago and otic syphilis about a year ago. Those are the patients with IV penicillin. And I felt like this is very important to review because, you know, I think it's important to understand the stages of syphilis because the treatment is different, the diagnosis is different. Just kind of review this quickly. Transmission, you all know that, okay? There is direct contact from person to person, so it doesn't sit on the toilet. So if somebody tells you there was not a sexual encounter, that doesn't fly. You know, there has to be, you know, a person-to-person contact to transmit syphilis. And of course, in this room, we are talking to OBGYN, and I'm sure you have seen this and witnessed this in your practices. Syphilis can be spread from mother to the baby, and that's the purpose of the discussion today. Some pictures to bring to some, I guess, risk factors first. You know, those are sexually active people who get syphilis through vaginal, anal, or oral sex. There is a picture of a lesion on the tongue. It can be anywhere on the tongue, on the genitals, and the key to that, it doesn't hurt. So that's really quite important when you're interviewing people, patients, and it's really important just like when you were in medical school. When I see a patient, I start the exam, mouth, ear, all the way down. Not necessarily do a pelvic exam on everybody, but it's really important to do a good history, okay, and to do an exam, just like when you were interns at any level of your practice. The patient is the best source of information. They will tell you their story. We need to listen, and while they are telling you the story, to hopefully think about the proper diagnosis. I had to put this picture and to kind of repeat already what I said, but I think this is a very visual. This is actually Anna's idea because she said, Dad, you need to tell the audience, you need to show them so they remember. I said, Anna, they remember these are doctors, but it's not like they need to put this picture here. So there is a sore in the first stage, body rash, and it can be all over. And the key, ladies and gentlemen, it is not pruritic. Okay, so this is a rash which doesn't itch, and that's the key to that. If it itches, it could be an allergic reaction, could be a ton of other things. Again, the patient is the best source of information. The lesion on the penis in Latin's uncus mole, it doesn't hurt. Okay, and that's the key. And then second would be rash. You see these multiple small pustules. This is why you need to put the gloves on, because you can bring herpes home if you touch a lesion, or spread in other places, or in this particular circumstance, Treponema pallidum can be spread from person to person if you don't put gloves on. Tertiary syphilis, that's your neurosyphilis, otic syphilis, syphilis of the eye, Argyll-Robertson pupil, remember from medical school, gummas and tabes dorsalis. Patient is trying to back up and he falls back. So those are some late stages of syphilis. The last one I saw in the VA patients many years ago, neurosyphilis, treated with IV antibiotics, but you need to always keep this in mind. Why? Because you will see some statistics. This is an issue in our society and all over the world. Do I speak too fast? No? Okay. Statistics. I intentionally put the statistics here to raise the issue and also show you some information. You can tell other people. You guys go to conferences, so we need to be all familiar. This is an old disease, ancient disease, and it's becoming a problem despite of we still have a lot of women with poor access to healthcare. And so on, but this is definitely something that I felt like we need to review. So, who are the risk? Who is at risk? It's young people, 20 to 40, male, primarily men, sex with men, and then there are some, unfortunately, large disparities in the United States as far as access to healthcare. So those would be the people, your African Americans, blacks, American natives, Pacific Islanders. So these would be the groups of people who are at risk. Why is this important? Because these are the patients or females in this particular circumstance who can come to the emergency room without access to healthcare, and you have to be looking for all these things that they can have. From diabetes, they can have hepatitis C. By the way, that's another guideline by your society to test expecting mothers for hepatitis C, give them the Tdap, lots of things which have to be done when you see women who do not have access to healthcare. How many people in this room have seen over the past year a female with no or poor access to healthcare? So now, if you go to New York, probably all hands would go up, right? Large population, 15 million people, that's different. We are very, very lucky in Omaha, Nebraska, having a beautiful women's hospital and our women having access to healthcare, and people like Dr. Patel talking on TV. Remember, during COVID, she was on TV encouraging women to get immunized. All of this is important because we are also public servants. We need to talk to people, talk to patients at any level to encourage them to get proper care, especially in a crisis situation. So these are the statistics. Nebraska, since 2017, almost 400% increase in syphilis rates. That's amazing. But it is what it is. We need to know this information and obviously come up with a reasonable approach how to tackle this. Primary and secondary syphilis. This is from the CDC's webpage as far as age group. In the middle, you can see that the age group on the left side of the graph, male and female, and you can see it's the young people, 25 to 30, where there are the largest amount of syphilis. when we see HIV positive patients primarily or anybody with an STD, we offer condoms. That's controversial. Some people feel like, why do we offer? I think this is important. I think, anything to educate people to prevent an STD, and especially in young people, including offering them condoms, in my opinion, is quite important. So these are the people with primary and secondary syphilis. I just wanted to show it to you that these are our young people. It's not just this. There is an opiate crisis in our society. There are large amounts of hepatitis C patients. This is our next generation, and why I'm showing that, because we really need to get this under control, because they are the people who will carry our torch. So we need to educate them and prevent any other communicable diseases. Essentially, it's the same which I already mentioned to you. These are the risk factors. It's very well described. So it's your young people, men sex with men. And then other risk factors would be your Native Americans because of poor access to healthcare, and African Americans, and Pacific Islanders, and people living in Alaska. There is, in some of these groups, there is hesitancy to go to the doctor, maybe poor access to healthcare, and this is very important. Do you guys get Native American patients at the Women's Center from time to time? No. So they must be going to, because there is a large Native American population in Nebraska and Iowa, so not sure, maybe they will go to another hospital, but they are high risk. So just if you see one, you need to do all the tests indicated for this patient population. Okay, primary and secondary syphilis in a graph format. On the x-axis, you see the years from 2016 to 2020, and on the y-axis, you see the rate. We already talked about this, but it's just kind of visually, you will store this in your memory. When you see these patients, you can see the rates are going up, these disparities, these are the risk factors, and white and Asian for some reason have the lowest amount of primary and secondary syphilis. Still, everybody has to be tested. We have everybody, as far as expecting mothers, and we will look at some guidelines of the CDC and your society who to test. Another graph just to illustrate to you. On the x-axis are the years. On the y-axis would be the cases. So these are the people who can acquire primary and secondary syphilis by sex and their sex partners. Very important to ask about epidemiological history, previous sexual exposures, previous marriages. Has the previous spouse been diagnosed with an STD? All of these meticulous, history taking, in my opinion, is very, very important, and I think it should not be skipped. Should be all collected and documented. Whether if it's you, whether if it's your student, nurse practitioner, doesn't matter, but somebody needs to do that. Congenital syphilis, another big problem. Now, obviously, if we see increase in syphilis in our society, we will see a rise in congenital syphilis. So on the x-axis, you see the congenital syphilis rates, and on the y-axis, you see who are at high risk. Well, obviously, mothers of American natives, American Indians, Pacific Islanders, Native Hawaiians, blacks. So the maternal syphilis obviously correlates with congenital syphilis. I just wanted to show it to you. When you look at it, I didn't realize it, until I really dove into this in great detail, how prevalent it is. Maybe not in our hospital because of what I just said, but we are very lucky that we have many patients with access to healthcare, and they come to see us. But there are other communities, and probably the largest amount with this problem is the South. You see the highest amount of syphilis. You see hepatitis C. There is also a problem with pre-exposure prophylaxis for HIV. So there are certain pockets in the United States where really these problems are much much higher and much more difficult to get under control. Syphilis rates in Nebraska. You thought we are better than other states. Well, we are actually not. You know, there are pockets of towns in Nebraska where there are more drugs, there are more STDs for some reason, and you know, but the syphilis rates are increasing even in Nebraska at an alarming rate. So if you since 2017, almost 400%, I think that is a huge number. You know the patient population, it's young people, you know. I'm raising awareness because that's you all maybe many of you have children where the school asks you to talk about this at the school, about STDs or any healthcare issues. And I think it's important because, as I said, we are also public servants. So if a school asks me, like I go to the Omaha Street School. Does anybody know where Omaha Street School is? That is in Benson, and that is a group of children or young people from very challenging backgrounds where really the parents are in jail, they were kicked out from school. Nobody wants these kids. They have mental issues, and so I go every year and just talk about STDs. And you know, it's a very simple discussion. You know, you'll just tell them, if you are bad, that's what you will get. But I think the message is, I mean, you're not going to talk like this in front of them, but you are just going to educate them that they are more vulnerable than other people to raise awareness. So very important, if any school asks any of you to talk about any healthcare issues, whether if it's diabetes in pregnancy or anything, please go and educate your the community. On the right side of the graph, you see number of reported syphilis by sex. All I'm trying to say is it's more in males. You know, even in Nebraska, between 2017 to 21, more in males than in females, and there is an upgoing trend. So just wanted to let you know that, and you can read the rest on the slide. And those disparities really bother me. You know, we are a melting pot. I'm an Eastern European immigrant. I was born in Czechoslovakia, so immigrants have been always close to my heart, you know, because I'm one of them. And maybe we as a society have to do a better job to take care of some of these underprivileged people like Native Americans and everybody goes to Hawaii, right? I was on the island of Kauai months ago attending a medical conference. You wouldn't even think that there are so many medical problems there, right? You just said it, whether it's syphilis, diabetes, you know, high blood pressure. Beautiful people, very, very welcoming and friendly, but they have their own big problems. Dr. Whitener, when I came here, immediately asked me about testing. So there is a new guideline for laboratory testing, just came out. I was done with this talk in January, and then I'm thinking, well, Dr. Tiffany Samashili would probably ask me, Rudy, where is the update of the 2024 testing? So I had to add some slides, and here they are. So if you look, so this is from 2024, straight from the CDC. Anna just lifted the graph and threw it up there for you. Looking at the traditional algorithm and then the reverse algorithm. So if you look at the traditional algorithm, this is what you remember from medical school. You do an RPR. If it's reactive, you do a treponema test. That is a test which stays positive for life. Once you are exposed to treponema pallidum, okay, that treponema serologic test is not affected by treatment, it stays positive for life. So that's the older version. Then you have a, if that's positive, so if the RPR is positive, treponema serologic test is positive, you know, then you have a patient diagnosed with previously treated or untreated syphilis. Okay. If the RPR is negative, then obviously syphilis is most likely is less likely. So you always go either by this traditional or algorithm, but there is a new one. Why? Remember at the beginning I told you about treponemas. There is Borrelia, there is leptospirosis, there are other spirochetes. And remember when you were in medical school, the Lyme's disease was only seen maybe in parts of Minnesota and East Coast. Lyme's disease is moving, so is syphilis. So you can have potentially positive, falsely positive RPR because there is a laboratory interference among these Borrelias. So this new testing, the reverse sequence is preferred. So you do a treponema serology test. This is EIA. You all know that. It's just this is a kind of an algorithm which the CDC really prefers. That's the reverse sequence. So if you have a treponema, you do a syphilis antibody. So that's what you order. In other words, so don't worry about EICI. It is the syphilis antibody. If the syphilis antibody is positive, okay, and then you do the non-reactive treponemal test, okay. And if that's negative, syphilis is unlikely. Then, if the treponema serologic test is reactive, then you do the non-treponema, the RPR, because the patient could have been treated, could have been exposed to syphilis. So if that's high, then you remember this from school. Then the patient most likely has been exposed to the treponema pallidum. So you have two positive tests. You have the syphilis antibody test, you have the RPR, everything is reactive, you are right here, okay? If the syphilis antibody test is reactive, this one is negative, the RPR, okay? You have one positive, one negative. Then you need to do something else. And the something else is to perform a second syphilis antibody test. And your options are EI and CIA. If that's positive, then you are dealing with syphilis. And if the second treponema antibody test is not reactive, syphilis is unlikely. This is maybe a little bit confusing, and I don't want to. It's better really to look at it, and you as a team kind of think about this and have this this is on the CDC's webpage. If you have a patient that you need to figure it out, you can certainly call me, but I think this is the best decision tree, how to diagnose people with syphilis. Any questions on this?
We're screening every pregnant person for syphilis. It's routine. We do it for every new OB. Are you suggesting that we change our screening process, or is this just a diagnostic?
I would do the new recommended testing, and that is the treponema serologic test. So this is your syphilis antibody, because that's really what the CDC is recommending. And exactly why, because you can have a falsely positive, falsely negative RPR. So if you order the syphilis antibody test and that is positive, the lab automatically reflects it, I hope.
Dr. Kotula,
Yeah.
let me ask this question. We know that there are two protocols for screening, and we know that traditional and the reverse. Do we know at this stage that one is better than the other? I thought that we haven't distinctly separated that.
I don't think so. It's one of them is more a traditional algorithm, and more is because of the maybe it's just easier for the practitioners to do it this way. If you just order, the RPR is really there, and we all did this in medical school. You did RPR, right? I think if you do an RPR, you really just should do it to monitor the success of your treatment. So let's say somebody, and we will talk about the management of syphilis. The RPR, so you go down this way, previously treated, untreated syphilis, then you give the expecting mother or the baby or anybody, you give them penicillin, then you check in 4 weeks, 8 weeks, your success. there should be a fourfold decrease. But RPR should be used only for that. And once again, these spirochetes can cross-react. Okay, none of this is perfect. This is preferred, and so you can order both to answer these guys' question. But this is the preferred algorithm if you are screening somebody. Is that clear? Because I think that's so you can order both, but you can order anything at the hospital, right? But I think we need to order tests which make sense, and that's why this is really quite important. That's why I wanted to pause here and just answer any questions, so you are not confused, but you don't have any questions about this. Okay, very important. And you all know this, and I just wanted to throw this here. On the x-axis, you see months and years. On the y-axis, you see the positivity of the test. The treponema antibody is this purple line. When you get infected, the antibody rises in 2 weeks, stays positive for life. That's the treponema antibody. The RPR is positive in 4 weeks, and if you don't treat, stays high. Okay, I have patients up to 1 to 200, 300, and then you give them penicillin, comes down. And if you treat appropriately, then it goes down. Doesn't always go to 0, but you should see fourfold decrease after you treat somebody, and you should periodically check. Why? Because patients can get reinfected. We will talk about this in your patient population. But this is a very simple graph to look at the trends of these tests. There are other tests. You probably don't order them, but why I do this here? Because if you have a neonate and somebody orders any of these tests, that also meets the criteria for syphilis. Dark field microscopy, immunofluorescent antibody, immunohistochemistry, silver stain, and obviously PCRs. These are tests which can be ordered, but I think these other tests that we mentioned are probably much easier. But maybe somebody wants to scrape off a lesion and send it to dark field microscopy. Many of you remember this from medical school. That's really not done very frequently, but it's available if you choose to do that. And the microlab would get absolutely excited about something like this because patients don't do this very frequently. In 2022, now we'll switch gears a little bit, talk about syphilis during pregnancy. Look at this number. In 2022, we had almost 6,000 pregnant women in the United States diagnosed with syphilis. That's alarming. And you saw these trends going up. So this is really, really striking. You all know what syphilis can cause: stillbirth, miscarriage, infant death. What we need to do, we know all of this, but we need to focus on prevention. And I will show you a slide at the end what the CDC is planning to do. We really have to do a better job in prevention. Well, as I said, educating people, educating families, go to communities where they may not come to us, talk about this, test, encourage people to do testing. Methodist does a lot of, there is a bus for mammograms, for other things, but there is no Paddy a bus to be doing testing like that, right? Well, maybe we need to come up with a bus, and Paddy and I will drive it and go to the communities and randomly test people for these type of conditions, because seriously, it's lack of timely testing. And this is a big problem. So to focus on some of these areas before you have a problem, I think it's paramount for our society. All women, and now hopefully we can answer or highlight some of these questions that you had or concerns. All women per CDC guidelines have to be tested at least twice. Most of your patients will come for a prenatal visit, so you test the person then. When they come for follow-up visits, we always have to ask them questions. Are you sexually active? With whom? We don't anticipate it's the husband, and Sometimes when I ask these questions, people look at me, say, this is a different society. We need to be, if you want me to help you and take care of you as best as I can, I'm not trying to be nosy. I need to know what's going on so I can order proper tests. Well, you know, you also need to order a hepatitis C test. Well, that's not something that you need to do twice in pregnancy, but once in pregnancy. But when the patient is telling you that I went to Chicago and I had some interaction there with somebody who is undergoing treatment for hepatitis C, you need to know that. You need to test her again. So this interaction and good relationship with any of your patients, whether if it's a 25-year-old expecting mother or a 75-year-old person from Hillcrest Meadows, Brookstone Meadows, we have to have good relationships to our patients because they will tell us their stories, and then we know what to do with them many times. And then we need to repeat it in the 28 and 32 weeks of gestation. HIV testing, very important, and other STD testing. Syphilis and HIV are not the only tests. There are the only STDs. There is chlamydia, there is gonorrhea, and one other emerging pathogen I wanted to bring to your attention is Mycoplasma hominis. Mycoplasma hominis is an emerging cause or etiology of urethritis. You don't see it very frequently. I diagnosed 2 of them over the past 6 months. Those were men with some risk factors. One of them had a homosexual, one had a heterosexual preference, but going to Vegas for different reasons. He was tested for everything. So I performed a urethral swab. It was really a punishment for this guy. He was just, urethral swabs we don't do very frequently. So I did that, and for sure it came back positive for Mycoplasma by PCR. Treatment is azithromycin, doxycycline. The reason why I'm saying that's an emerging pathogen, and if your patients, if you're unable to identify, the etiology of urethritis, don't forget about Mycoplasma hominis or ureaplasma. And it is a PCR. They cannot just provide the urine in the cup. So worry about all STDs and provide education, sexual history, and so on. Treatment of syphilis and in pregnancy, not much really changed. It's on the slide that you can just take a peek and look it up in the Sanford, Google it. Nothing much really changed. What is important though, that ceftriaxone is an option, but there are insufficient data. So if you have somebody with allergy to penicillin, Dr. Carr, what's your first question if the patient is telling you I'm allergic to penicillin? What would you ask her?
What the reaction was?
Don't ask for an ID consult. You can. I'm happy to see that. But yes. What was the type of the reaction? If the patient is unsure, the next question, have you taken cephalosporins, Caflex? If that's still not an answer, you can always call pharmacy and they can check in 5 minutes previous exposure to cephalosporins, okay? So that's a very easy approach to antibiotic allergies. But certainly you can always call me. But data are insufficient to treat syphilis with ceftriaxone, okay? As far as maternal infection and congenital syphilis, it's available, but that's really if you have no other ways to approach it. Because if somebody has a true allergy, you really should desensitize. There are protocols for that. Pharmacy has a protocol. Allergy immunology can help you out, but you should really desensitize the patient. For primary or secondary, there is one dose, and then if you diagnose syphilis before 24 weeks of pregnancy, you treat and you repeat in 8 weeks at delivery. You must know if the patient, that the patient received the penicillin because you gave him the penicillin. But first of all, how did they respond? Not everybody has the same response. And number 2, did they get reinfected? So that paranoia which is in our head, any other STDs, any exposures, and people I'm sure you have seen that, people get reinfected. So that history taking, and if there is any concern that there could be reinfection, you need to retest. If somebody was treated, diagnosed and treated more than 24 weeks following the gestation, you repeat the test at delivery. And if it's positive, you obviously have to treat. Lovely term from medical school, Jerisch-Herxheimer reaction. I think this is a lovely term. I'm sure everybody in this room knows what it is. When you give somebody penicillin, the treponema fights back because you are attacking the treponema. So there is a huge cytokine release, tremendous cytokine release. Who in this room has seen Jerisch-Herxheimer reaction? So blood pressure drops, rash, patient gets sick. It looks like an allergic reaction, and then it really isn't. So this is a self-limiting problem, related to like the other good example would be sepsis. You are giving a patient an antibiotic and you are disrupting the lipid membrane of the gram-negative bacteria. Huge cytokine release, fevers, and so on and so on. This is similar. The bacteria are trying to fight back and they will not win because we have a very powerful medication in this circumstance. It's penicillin to hopefully conquer syphilis. When you are seeing an expecting mother, there are other things that you need to do. You need to do a sonographic exam, because you have to study the baby. If you see any signs in utero, which is your ascites, hydrops, thickened placenta, these are certain signs that you can suspect congenital syphilis, and and also if you see these signs, you have to wonder if the treatment really is efficacious in the mother. Because if you give them the proper dose, proper CDC guidelines, you hope that there is going to be less likely the possibility of transmitting syphilis from the mother to the baby. Healing in delivery. I have not seen it, and there is nobody from Dr. Minderman's team, but you would know about this too. Anybody in this room has seen images of the one who has seen that is Kelly Awad, and he was in Texas someplace in his training. This is really rare, but some of these conditions which are rare, at least these pictures should be shown, because that's how these babies look. I mean, they look like, that skin is shriveled, and that nose is kind of unusual. So I think we need to know some of these things, because there may be a woman coming in the doorsteps and she will deliver in 2 hours, right? You don't have the time. I mean, you will order these tests, but you may not have the time to get these tests back. So you need to look at the fetus, and if the fetus at the newborn, and if the newborn looks like this, that raises some serious concerns. So who needs to be screened at delivery are listed on this slide, with poor or inconsistent prenatal care, illicit drug use, homelessness, multiple sexual partners, and so on. When you are discharging the mother, okay, whether if especially the mother didn't have proper care, then you should definitely do a syphilis test, and because this is something that you is easily treatable if you diagnose the problem. Coordinated care. If there is syphilis, there has to be follow-up, repeat titers monthly. This is all per CDC guidelines. So I'm not saying that you should do it, but when the patient goes back to when the mother goes back to the primary care provider, the baby goes back to the pediatrician, it's important to arrange for a follow-up. Congenital syphilis, another scary slides. On the x-axis are the years, on the y-axis are the number of congenital syphilis. Just like I told you, the maternal syphilis correlates with the congenital syphilis. That's not rocket science. And the cases over the past 10 years in the United States went up almost 800%. Isn't that something? Despite of all the, listen, HIV, we have 20 active drugs. And the rates of HIV per year in America went from 40,000 newly infected to 38,000 newly infected. So it's another big societal problem. So we have some serious issues that we need to deal with, not just Ukraine and the southern border. We have so many issues within our country that we need to fix and be aware. Congenital syphilis is one of them. Stillbirth, miscarriage, neonatal death, morbidity, mortality, deafness, and there can be some long-term effects of a person not recognizing syphilis, not reaching this. So if you have a neonate with syphilis, what do? Obviously, hopefully the mother is able to give you some information about her treatment, which may be a problem. You know, people in our country travel, they move. I just saw somebody from Chicago who moved, and it really took him almost a month to get from the Chicago Public Health Department to get information how she was treated. And she really wasn't sure. And she got reinfected. So she's reinfected. Was she treated? What was the response? So it's really important to get proper records. So adequacy of the treatment of the mother, you know, we need to look at the testing of the mother and the baby at delivery to see if there is a response in the mother as far as treatment of syphilis. We need to test obviously the neonate for HIV, you know, you know, we have to be looking for other things like heat drops, jaundice, rhinitis, skin rash, and some of these other findings on the picture. The diagnosis of the neonate with congenital syphilis can be done by three things. It's either serologic testing, okay? It can be the physical exam, you know, and also remember the table with some of these tests that you take a sample of the lesion, dark field, immunohistone, chemistry, and so on. That also meets the criteria for congenital syphilis. And the last slide will be, which I will show you, will review how to manage it appropriately. But just to finish this, CSF analysis is indicated in some of these babies, and you know, to make sure that they don't have you know, syphilis of the CNS. Treatment is on the slide. It's penicillin. It is the best treatment, and you treat this for 10 days. One of my last slides, and this is extremely busy. This is why I created those. My office ladies were kind enough to do that, because this is, I'm not saying confusing, but there's just a lot of information. So if you are suspecting congenital syphilis, you divide it into three major areas. If the infant meets criteria, if the mother meets criteria, and if none of these meets criteria, but there is some history as far as previous syphilis. So if the infants meets the criteria, you know, by physical exam, or when the mother was treated, okay, and then as far as the infant's titer is more than 4-fold higher than the mother's, that raises a concern, okay, or some of these other tests which I showed to you on the table. If that all is positive, you go to the square number 2, and that's your CSF analysis, and so on and so on. Then you treat. So that's quite straightforward. Then, if that's not the case, then you go and evaluate the mother. I mean, you always evaluate the mother, but if that's maybe a more challenging situation, then you ask the mother about treatment. Was she treated adequately or inadequately? Okay. If that's not the case, you do this essentially the same testing. Give penicillin. Okay. If there were none of these abnormalities on this square up here, then you still give a dose, and you give a single dose of penicillin. And then there is this gray zone. You know, the mother is a maybe, you know, infant really doesn't look like somebody with syphilis, then you go to the additional criteria. And that is to review, and that's when these records are important. Sometimes the patient remembers, sometimes they don't, Was the mother adequately treated, And there is no concern, one more time, for infection. So when these expecting mothers come to you, always ask them about possible STD infection, including mycoplasma, okay? Which you can easily do. And if there is no concern, none of this, you don't have to do anything, okay? But then, if there was treatment, you still have to review the response, okay? If there is good response, no treatment is indicated. If this is kind of in between, and this is why the RPR plays a role here. The RPR is paramount to order, because that's how you monitor the response to your treatment. The syphilis antibody stays positive for life. That doesn't change. Shows you the graph. But the RPR or VDRL, however you want to use it, that's what you order and to monitor the treatment response or infection, right? Somebody comes back in 3 months and the RPR is high. Well, something happens, right? So this is a very important algorithm. Any questions about this in anybody?
I have a couple quick questions just to clarify. So if you're saying greater than a fourfold, I think you called decrease in the response on their antibodies, correct? So
RPR.
or RPR, excuse me, that's what I meant. But anyway, so if there's a fourfold increase or decrease, you say, hey, that's been treated effectively. But that's different based on where they got the labs from. So if they had it done in Chicago, then you had it done here.
That's a good question. I certainly hope that these are CDC guidelines, and the labs across the United States. I mean, there are some off labs, but then the standard labs should all be under. This is why I was hoping that Dr. Karg would be maybe better to answer the question. I think there are certain laboratory standards. So in general, the labs for this particular issue should be the same wherever you go. Now there are some other labs. For example, remember Lyme's disease, chronic Lyme's disease. There are some very strange labs that we get results from, and I'm not sure that's usually not even paid by the insurance. Those are kind of offshore labs, but syphilis testing should be standard. So if there is a non-fourfold decrease, you need to retreat because something happened. Either the patient did not respond to the treatment, or she got reinfected.
And then can you then repeat again on timing of that? Like where we expect to see that decrease? I know we said we're rechecking
8 weeks.
8 weeks.
So you treat, and in 8 weeks it should decrease. And this is why when you have a patient less than 24 weeks, you treat, you repeat in 8 weeks, and then they deliver. Even my HIV patients, I don't recheck them in 1 week, usually in 8 weeks. And then if the level is dropping, fine. If they tell me they went to Mexico and did some things which they shouldn't, maybe, then you need to recheck.
And then
Yeah.
you know the cost difference between as far as antibody testing versus RPR, just out of curiosity? Just because I know we get complaints from patients when we run a GC and chlamydia on them and they have to pay out of pocket. And then now if we're gonna maybe consider switching over, what that cost difference is?
I don't know, like I will find out and will let you know, because there's nobody from the lab here, right? That's okay. I will find out for you. But you are saying that when you order GC and chlamydia, you have to pay for it?
In our gynecology patients, yeah, happens a lot. Even if it's a high risk patient and you document that well, a lot of times they get.
Well, our healthcare is not perfect, right? So if somebody has to pay for GC and chlamydia, I think it's in their own interest not to lose the baby and not to transmit it to other people and so on. But anyway.
What would be your recommended screening protocol for someone who's had previously treated syphilis? So I understand they changed the protocol for how you test people who've never had it, how does that affect? Because we see patients from time to time who've had successfully treated, documented response, got the letter from Douglas County Health, all those things. How should we screen those people in their pregnancy when they come in?
If you have a previous treponema test that stays positive for life,
Right.
any dynamics after the treatment, I would just go straight to the RPR, because if you are reinfected, it's really the RPR which will go up and down. So I don't think so any insurance.
So for a previously treated patient, you would order an RPR at their first visit.
Right.
Is there a level of the RPR where you would say they were reinfected or failed and just treat them empirically, or do you need to order several RPRs to see a rise in it before you can start treatment empirically?
If you order the RPR, they will usually give you a title, okay?
Right.
And then the title, usually I accept the title 1 to 2, 1 to 4. If it's higher, then you have to start wondering. And just like for medical school, if a test doesn't make sense, repeat it, right? I mean, but if you see rising of the title, it's also when the patient is telling you that there was no activity, okay, and the patient is not lying, even if you have a good relationship, then maybe you can just watch it. But when the patient is not sure, or when you really want to pursue it, that's another reason to order the test.
So if it was over an RPR of 1 to 4, 1 to 8, you'd consider talking about treatment,
I would
or at least retesting.
I would definitely do that. It should go to 1 to 2, 1 to 4, and then just stay there. And don't forget also the cross reactivity. So if this patient will go to Minnesota, gets a tick, can go up. That's why then you have to really start analyzing the whole case. This is why the falsely positive RPR, there are about 5, 6 other reasons. But those spirochetes can cross react. And there is, ladies and gentlemen, there is, I'm sure you know that Lyme's disease in Nebraska for about 2 years. So if somebody gets a tick bite in Omaha, Nebraska, don't ignore it. That could be Lyme's disease. So has been well documented.
How come there has not become and maybe there is, a resistant syphilis?
I love that question. So nobody knows. Treponema pallidum does create, okay, the principle of resistance is the exposure to the bacteria. If you expose bacteria to an antibiotic, the bacteria fights back. Good example is Pseudomonas aeruginosa. Pseudomonas has 7 mechanisms how to render an antibiotic ineffective. Treponema pallidum only makes beta-lactamase. So why not resist it? I don't think anybody knows that. But thanks God, right?
Yeah.
So that's one of the group B strep. There is no evidence of group B strep resistance to penicillin in the world, even though you see other gram-positive bacteria or MRSA and other bacteria, there is emerging resistance. So I don't think so anybody knows that, but it makes the beta-lactamase, but it doesn't create a situation where the antibiotic would be ineffective because it can use penicillins and cephalosporins for the management of syphilis. You all know that talk, test, treat, very simple. Talk to your patients, test your patients for the things that you should be testing and treat them and have them to come for a follow-up. CDC action. Obviously, the CDC is alarmed, not just people in this room, about these trends, because there is apparently even the maternal mortality is increasing in the United States. I think I sent it to Emily maybe about 6 months ago. Remember that article I found in JAMA? And I remember the percentage that there is a concern with maternal mortality, which is going up. And I think you mentioned because of high blood pressure or some other, or maybe Tiffany, one of you mentioned that. So those are really concerning issues, that we need to ask women to come for proper care. We need to manage their high blood pressure, their diabetes, their syphilis, and just everything. So it's a multidisciplinary, multi-societal approach. So we have healthy offspring. We need to develop tools, how to impact, whether if it's billboards, texting, however we will communicate with the patients. guidelines for syphilis, easy guidelines, because, if we are in a large community with tons of medical providers, but how about the small town? How do small towns deal with that? There may be a stigma. Good example, if I want to get a hepatitis C patient from Wahoo, Nebraska, I probably need to pick him up. They will not come here. For them to come to Omaha, Nebraska, and to even sharing the stigma of hepatitis C is a total roadblock. So smaller communities, Hawaii and Pacific Islanders and all of these, that's where we need to go, because that's where the problem is really out of control, as you saw from the slides. So how to reach these communities, how to educate, and of course funding. But we have funds for many other countries, so we have to find funds for our own citizens, in my opinion. Okay, and screening, education, that's the way to go. So we made it, 8:05, so I'm slightly late, sorry.
So do you think that the incidence of syphilis is high enough that we should change our protocols and do screening more than once on all women or at-risk women, or?
I think
Go ahead.
you should do it twice, Bill, but again, how often do you see your patient comes, so somebody diagnoses the pregnancy, then they come to you, what, in 1 month after the diagnosis of pregnancy, roughly? Okay, how often do you see them? How often do you see them throughout pregnancy? Every 2 months, every 3 months?
We'll see it monthly till 28 weeks, every 2 weeks till 36, and then weekly.
Okay, so every time they come back, ask them the same question. Are you eating? Are you taking your folate? And all of these other questions. Give them the Tdap, screen them for hepatitis C, and ask them about travel history. Not everybody lives in a monogamous relationship, So ask them some of these questions. Maybe the husband left the wife, right? I mean, there's just so many things which can happen. So all of this is important. If you don't have the time, have the nurse collect some of this information, have the nurse practitioner collect it for you, so you can order appropriate testing. So if the patient is telling you that there was some marital discord, and the husband maybe found somebody else, but then came back, that's an indication to ask about STDs and actually test for STDs. So every patient is different, but otherwise, if everything is quiet, there's no other behavioral access or marital discord, I don't actually need to check syphilis monthly. Did I answer your question? And so it's case by case.
I guess, I wouldn't necessarily do it monthly unless that you saw that, but
Yeah.
do you think there should be routine screening twice during the pregnancy?
Right now, we're just doing it.
We're just doing it at the initial visit.
Yes.
We haven't done the 28-week test.
Okay, you haven't done that. I would not be against that, to be honest with you. To do it twice. So,
And we shouldn't just do it here. It should be citywide, because if it's going to be a standard of practice that our standard isn't higher, shouldn't be any higher or lower than anybody else's.
and then the question is, which probably you have, will the insurance pay for it, right? That's always a question. It's not an expensive test, but, if people are on a budget, how much could be probably $100, $150? Nothing is cheap. So I would consider doing it twice.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.